to introduce Dr. William Breitbart. For those of you that don't know him, he is a psychiatrist, psychosomatic oncology clinician, researcher, author of countless articles, chapters, and books, my friend and my mentor who has greatly influenced my work and my personal meaning through my legacy lived and living. Dr. Breitbart is chairman, the Jimmy Holland C. Chair in Psychiatric Oncology, and chief of the Psychiatric Service, Department of Psychiatry and Behavioral Sciences, Memorial Sloan Kettering Center in New York City, New York. He is the 2009 recipient of the Arthur Sutherland Lifetime Achievement Award from the International Psycho-Oncology Society. He's the 2011 recipient of the Thomas Hackett Award for the Lifetime Achievement from the Academy of Psychosomatic Medicine, and the 2013 recipient of the Jimmy Holland Award from the American Psychosocial Oncology Society. Dr. Breitbart is the past president of the Academy of Psychosomatic Medicine, as well as the International Psycho-Oncology Society. Dr. Breitbart's research efforts have focused on psychiatric aspects of cancer and palliative care. He has had continuous NIH R01 funding of investigator-initiated research since 1989. His most recent efforts have focused on meaning-centered psychotherapy for cancer patients and current adaptations. He has over 400 peer-reviewed publications, chapters, and review papers. Dr. Breitbart has edited and written 12 textbooks, including Psycho-Oncology, the first, second, and third editions, the treatment manuals for meaning-centered psychotherapy in advanced cancer patients, and individual meaning-centered psychotherapy for advanced cancer patients, both I think which are available outside, and the forthcoming meaning-centered psychotherapy in the cancer setting from Oxford University Press. And finally, Dr. Breitbart is editor-in-chief of Cambridge University Press International Palliative Care Journal, entitled Palliative and Supportive Care. It's my honor to introduce him to you today.
Hi, good morning. Thank you very much, Marie, for a wonderful introduction. I've been introduced about 1,000 times now at lectures. I'm getting to be an older clinician. And I just wanted to say, Marie, that this was probably the most recent introduction I've ever had. So thank you, Marie. I also want to thank Dr. Wong and all the folks involved in the conference for inviting me. This is my first time attending this conference, and it's been an experience. Thank you, Paul. Glad to contribute. My talk today is about working with existential issues and meaning in advanced cancer populations, and I'm going to focus on a novel intervention that we've developed and tested in randomized controlled trials, which we based on Viktor Frankl's work and logotherapy in general, called meaning-centered psychotherapy. And so that's what I'll talk about in the time that we have together. There's a Talmudic question, which is, what is truer than the truth? And the answer is the story. So this is the story, said in a very Trump-like New York accent. This is the story of meaning-centered psychotherapy. As Marie mentioned, I'm at Memorial Sloan Kettering Cancer Center, and my training is both in internal medicine and general psychiatry. And in 1984, I went to Memorial Sloan Kettering to do a fellowship in a new emerging field, a subspecialty of psychosomatic medicine called psycho-oncology. And I went there to work with my mentor, Dr. Jimmy Holland. And I've been there ever since. Over the course of my career, I've become interested in a variety of different issues, but shortly after being there for about 5 or 6 or 7, 8 years, I began to focus more and more on the interface of psycho-oncology, psychiatry, and palliative care. And over the last 20 years or so, my work is focused on trying to expand the concept of what adequate palliative care really meant. In fact, what I tried to do is expand the concept of adequate palliative care to include a focus that was not just on pain and physical symptom control, but also included psychiatric, psychosocial, existential, and spiritual domains of care. And Meani-centered psychotherapy, as we developed it, focuses on those existential and spiritual domains of palliative care. I've tried to do that not only in my research, but also in some of my writing and teaching. This is the first textbook, Handbook of Psychiatry and Palliative Medicine, which I co-edited with my colleague Harvey Chachnoff. Some of you may have heard of Harvey's work in dignity therapy. It's now in its second edition. We call this the Book of Names. It has about 38 chapters from the biggest names in psychiatry and palliative care and psychosomatic medicine, psycho-oncology. The names are incredibly impressive. The chapters themselves aren't that good. You wanted the truth, right? I told you I was going to tell you the truth. The names aren't, but the names are great. So we call it the Book of Names. Right. More recently, we came out with a textbook, a briefer book. It's a shorter version, co-authored with one of my junior faculty, Yezhny Alisi, and here there's just two names, but the content is extremely fantastic. It's huge. It's huge. It's terrific. So we don't call it the Book of Names, we call it the Haggadah. There is a part in there about the Jews leaving Egypt. It's at the end of the book. Oh, and as Marie said, the last 15 years I've been editor-in-chief of Cambridge University's International Palliative Care Journal called Palliative and Supportive Care, and it's the only palliative care journal that focuses on psychiatric, psychosocial, existential, and spiritual domains of care. So it's got a high impact factor now. It's about close to 3, and we come out 6 times a year, and that's been a very important part of my work as well. And we've also been we published and produced the Bible of Psycho-Oncology. We're going through all of the Jewish sacred texts, Psycho-Oncology, the textbook of Psycho-Oncology, which is now in its 3rd edition. One of the things that I do at Memorial Sloan Kettering, besides being the chief of the psychiatry service and the chairman and all that, we have 6 laboratories in our department. And I direct the psychotherapy laboratory. That's the official name of our laboratory. In the hallways, people call our laboratory the laboratory of despair. It's not because all the faculty are despairing about not getting grants and things like that. We actually do okay with that. The reason they call it the laboratory of despair is because of the kinds of topics that we study, as you can tell. We're really kind of focusing on what I like to call the meta-diagnostic problems of patients with cancer. Most psychiatrists who are trained traditionally in the American system, or even the Canadian system, other systems around the world, we're trained to either establish the presence or absence of a DSM or RDC a psychiatric disorder or diagnosis. If there's no diagnosis, we feel we don't have anything to contribute. There's no medication to give. But we've been working with what I call meta-diagnostic problems: hopelessness, loss of dignity, demoralization, loss of meaning, and we started out a great deal of our work looking at the problem of the desire for hastened death and the wish to hasten death. And it was really through that work on desire for hastened death that we discovered a variety of contributors to desire for hastened death that led to a path that brought us to try to understand the role of meaning in despair and existential despair, and ways of trying to intervene with that kind of despair due to loss of meaning. So in terms of our studies of desire for hastened death, we did a series of studies, and the first pass of those studies suggested that unrecognized, untreated clinical depression was a major contributing factor. But it only made up about 50% of the variance of why patients have desire for hastened death. We followed that up with studies that looked at, in both terminally ill AIDS and terminally ill cancer patients, we followed that up with studies looking at what happens when you treat depression with antidepressant medications, psychostimulant drugs, for instance. What happens to desire for death when you effectively treat depression? Turns out desire for hastened death remits when you treat depression effectively. But what we also learned from those studies is that there were other variables besides depression that must be contributing to desire for hastened death, because we didn't have the full explanation from depression. And those further studies suggested that things like lack of social support, uncontrolled pain contributed. But then what was most interesting was that hopelessness, independent of depression, and loss of meaning were very important individual and synergistic factors that contributed to desire for hastened death. So I had just come off doing a set of studies, pharmacologic interventions, looking at, okay, depression causes desire for hastened death, the kind of despair that leads to desire for hastened death. Let's give a drug and treat depression. I didn't have a drug for loss of hope or loss of meaning. So being a well-trained psychiatrist, I said, well, I have to try some psychotherapy. I was quite disappointed at that prospect because I had very little, I didn't think I had adequate training. So that's what this talks about. It's about the focus that we then began to place on loss of meaning, spiritual well-being, and hopelessness. We did this, we developed a sort of a meaning-based kind of psychotherapy, meaning-centered psychotherapy, understanding that meaning-centered psychotherapy would exist and would lie within a framework of existential psychotherapy, existential philosophy and existential psychotherapy. And important to developing these interventions was the fact that there were some unique characteristics of human beings that separated us perhaps from other animals. Some people will argue with me when I show this list. They think that their dogs are aware of their own existence. And then I ask them to do a mirror test, which is to have their dog look in the mirror. If the dog goes like this, then they are aware of their existence. If they bark at it, then they probably not. But some dogs may be aware. Some dolphins, who knows? I'm not sure. Perhaps some other apes. Perhaps some other apes do. But nonetheless, it's certainly true for us. So Kierkegaard taught us a few hundred years ago that human beings are unique and that we're aware of our existence. And as a result of this awareness of our existence, we have two emotions, awe and dread. It's awesome to be here in Toronto in front of you, ordering room service from this hotel. It's awesome. Has anyone tried that? Yeah, okay. And it's dreadful to order room. No, it's dreadful that we're mortal. We die, and we can die at any moment. I might not make it through this talk. All right, just prepare yourself. Some of you we may have to call 911 for someone. Right? But also what comes with this realization that we exist is this existential obligation to do something about our existence, responsibility. What is our ability to respond to our existence? We have a responsibility to create a life. And Viktor Frankl later would talk about creative sources of meaning, and that's where it all begins. You have this responsibility to create a life, to create a unique life. Oscar Wilde said, live your life, everyone else's is taken. I didn't listen to him, but to live a life, a unique life to its fullest potential. Not all of us do that. When you don't live your life to its fullest potential, you experience what's called existential guilt. And one of the best examples of that is Albert Einstein's last words on his deathbed, which, does anyone know what they were? Albert Einstein's last words were, "If only I knew more mathematics." Okay? He didn't feel he had done enough. Theory of relativity wasn't enough. You know, wasn't quite enough. Could have done more. Right? So so your responsibility is to create a life, a unique life, living to its full potential, a life of growth, direction, transformation, a life of meaning, to become an effective, valued member of a culture and a society and a world of meaning, perhaps, either a meaning that's given or a meaning you create, right? Or the culture creates. Viktor Frankl taught us that meaning making, or the need to live meaningful lives or create meaning in our lives, is a basic motivational force of human behavior, human characteristic. So it's probably only we human beings that focus, that need to have and create meaning in our lives. It's the defining characteristic. The other thing that's unique about us is connection. We need to be connected in order to survive as human beings. It's essential to human survival, and that's at the essence of human experience. And this connection is not merely to each other, but it is also to time, to the past, present, and future, to something greater than oneself, and as I've begun to discover in my work, connected to yourself, to that part of you that's self-aware, to be connected in that way as well. And then finally, human beings are unique in our capacity to transform. When we encounter limitations, suffering, Carl Jasper's called any encounter with limitations suffering. That's how I define suffering. And so there are all sorts of things that limit us as human beings that cause suffering. In my world of cancer, a cancer diagnosis that limits your prognosis, your time is now limited. That's a profound source of suffering, profound experience of suffering that can occur. So we're unique in that we have the capacity to find benefit and grow and choose our attitude towards suffering when we're confronted with limitations, when we're confronted with uncertainty, etc. So we're the only species that create hospitals and cancer centers, right? We're the only species that undergoes plastic surgery willingly. Now, I have a friend who made their dog do plastic surgery, but I don't think the dog asked for it. But I keep going back to the dogs. I don't own a dog. Maybe if I owned a dog, I wouldn't make these comments. I had a goldfish, but the goldfish died very quickly, and I was traumatized, and I should need trauma therapy. Okay. So in my world of cancer, what happens is when, in life, when you get to have as much gray hair as me or as my friend over there, or a few of us in the room, life teaches us that there are some existential facts of life, what Viktor Frankl called the tragic triad of suffering, death, and guilt. That in our lives we will inevitably encounter that. We'll encounter suffering that we can't avoid, limitations we can't avoid. We can't escape death. We can not pay taxes, but we can. And there's a lot of uncertainty about death. When, where, how, with who, things like that. And guilt is that existential form of guilt that I was talking about. Like what Albert Einstein's last words, or and so you if you get old enough, you encounter you are aware of these tragic existential facts of life. Which when you're a 26-year-old young man who develops osteogenic sarcoma that's metastasized to all their lungs and organs, you have a premature confrontation with these existential facts of life. And so what we've seen clinically is that there are patients who encounter these limitations, these existential facts of life. And some of them have the resilience to maintain meaning. They go through the experience. They may even be using denial and just go through this experience. The threats really aren't real. There are some unique individuals who actually, because of the limitations of time, etc., actually come more in touch with, become closer and become more attached and connected to the urgency, the importance of living life with a sense of urgency. And they appreciate every moment of life and every experience much more vividly. So they actually have an enhanced sense of meaning in every moment, and they are able to reorganize their priorities and focus on things that are more important to them. They give their lives meaning, beauty, connection, love, etc. But a very large segment of patients that we get to see clinically are folks who've, because they're confronted with these existential facts of life, lose their sense of meaning, have a profound sense of loss of meaning. And those are the patients for whom I found myself really inadequately prepared to try to help, with the kind of the sense of loss of meaning and the despair that goes along with that. When we talk about meaning, we're talking about something that also is connected to this concept of spirituality or spiritual well-being. And there are there are thousands of definitions of spirituality. We've been using the way we've been looking at spiritual well-being and our concepts of spirituality and where meaning fits into that really was informed not only by the literature, but also by David Sella and his group's development, George Frechette, the development of a scale of a facet spiritual well-being scale, which has components of faith, and a subscale for faith and subscale for meaning. So our construct of spirituality, spiritual well-being, involved concepts of both faith and or meaning. And we were trying to develop an intervention that could be used in the medical setting, an intervention that was secular, an intervention that didn't require, didn't have to worry about, well, is the patient religious or not religious? Is the clinician religious or not religious? Do they have the same faith system? This, that. We wanted to take religious belief and faith out of it. We wanted to develop a language of spirituality that was universal. And we thought focusing on meaning was this language of spirituality that could be universal, regardless of religious belief or not. Of course, some people derive meaning out of their religious beliefs, which is fine. Other people don't. But if you focus on meaning, it allows you to have that discussion. So faith, and the fact of the matter is, I'd like you to believe that it's very black and white, that faith is basically religion, organized religion, and meaning is secular. But the fact is, it's quite, it's more gray than that. So faith can obviously be a belief in a higher transcendent power that you identify as God, and you express that through participation in the rituals and beliefs of a specific organized religion. That's what a lot of people will talk about when they talk about faith. But faith can also be faith in gravity, or faith in science, or faith in the unknown, or faith in nature, etc. Einstein would have said, photons. Faith in a transcendent power usually sees this as external to oneself, but also could be internalized. That which is holy in me, the breathing of Namaste. So faith isn't always just organized religion. It can be something that we now in our cultures talk about spirituality. I'm spiritual, but I'm religious, for instance. Meaning, what we're really talking about here with meaning is that having a sense that your life has meaning. Either having that belief, my life has meaning, or the experience, I'm living life meaningfully. I'm having a meaningful experience living fully as a human being. It involves this belief that you're fulfilling a unique role and purpose. It comes with this responsibility to live to your full potential. If you're able to approach that, achieve some kind of sense of peace and contentment, or even transcendence through connectedness with something greater than oneself. That's one definition of meaning, which we've used. We've started to evolve that over time. We've also started to see meaning not merely as a cognitive process or a belief. Oops.
Meaning of the slide.
Alive, or being like, it's almost like being in love with being. It's the experience of being, becoming, having been. It's an experience of connection and transcendence, care, time, attitude. So it's also the experience of freedom, to be free, to be our true selves, authentic selves. So we were thinking, okay, so this idea of meaning seems to be important to us. Is it important to patients? Is it important at any practical level? Is it useful to patients? This is a study by one of my fellows, Alison Odell. She looked at a sample of about 250 cancer patients. She said, now that you have cancer, what are your needs? And what was really interesting is that about 42% said they needed help finding hope. And this doesn't work. 40% finding meaning in life, finding peace of mind, spiritual resources. So it seems like it's an important issue to patients as well. Is it just a Western phenomenon? Is it just us Western societies that are Western societies that find this idea of having an individual meaning important? It turns out to be that even in Asian societies, these things are relevant as well. This is a study by my friend Takahisa Morita. By the way, I only quote studies by friends. It's one of the limitations that you have to take into consideration. A sample of 160 Japanese cancer inpatients, what were their existential concerns? Meaninglessness, hopelessness, being a burden to other, loss of social role, feeling around with it. So meaning, purpose, quite important, even in non-Western societies. This is a study that shows that if you can sustain a sense of meaning, it actually impacts on your ability to sustain a good quality of life with physical symptoms like pain or fatigue, even if they're quite severe. So this is a study looking at pain and fatigue. And what you see here is if you are able to sustain, if you're someone who sustained a high sense of meaning, you're more likely to report a good quality of life despite the pain and fatigue than if you have a low sense of meaning. And the same thing actually was true for faith, but to a slightly less potent degree. We started to look at the relationship between meaning and spiritual well-being in psychological distress variables. And here's a study we did looking at depressive symptom severity in patients with advanced cancer. And you can see that if you score high on the spiritual well-being scale, you have much lower levels of depressive symptom severity. And it turns out that it's not the faith subscale of spiritual well-being that buffers against depression. It's not how religious you consider yourself, but it's whether you're able to sustain a sense of meaning. So meaning seems to buffer against physical symptom burden distress. It buffers against depressive symptom severity. Same thing holds true for desire for hastened death if you have high levels of spiritual well-being or meaning. A hopelessness if you have a higher sense of meaning, you're less likely to be hopeless, and you're less likely to have suicidal ideation. And if you look at this triad of hopelessness, desire for death, and suicidal ideation, they're all highly correlated with depression. They're not that correlated at all with faith, but meaning is even more significantly correlated with this triad of hopelessness, desire for death, and suicidal ideation than even depression. So it turns out that meaning, being able to sustain meaning, helps buffer against physical symptoms of stress, depression, hopelessness, suicidal ideation, desire for hastened death. We thought that if we were able to develop an intervention that sustained or enhanced meaning, we might be able to benefit patients in those areas. And this is a meta-analysis that recently appeared that showed that meaning was related to almost every distress variable studied in a meta-analysis of 62 studies in which meaning in life was measured. So meaning in life has negative associations with almost every kind of cancer-related distress. So we turned to the work of Viktor Frankl and logotherapy. I'm not trained as a logotherapy, I never studied logotherapy. What we did in developing meaning-centered psychotherapy is we inundated it in Frankl's work, read all of his books, and tried to distill from that concepts that we thought might fit into a brief, manualized, structured intervention that was where each session was partly didactic and partly experiential, where we thought we might be able to have some kind of impact on being able to sustain or enhance meaning in patients' lives and then benefit them in those ways that I just mentioned. So some of the basic concepts that we utilized in developing the intervention were some of Frankl's concepts about the importance of meaning in life, that life has meaning and never ceases to have meaning. Or that we added this because we thought it was a little bit more relevant or sophisticated in the sense of it's less dogmatic, that the possibility of creating or experiencing meaning exists until the last moment of life. It didn't require a dogmatic belief, life has meaning no matter what, because many of our patients can imagine a circumstance where there really is no meaning. As therapists, what we tell our therapists is you've got to believe that life has meaning, that there's the possibility of experiencing or creating meaning, because patients are going to try their best to convince you that there is no meaning. So you have to really believe it. The second is this idea that the desire to find meaning or create meaning in life is a primary motivating force of human behavior. And then finally, that we have the freedom of will to find meaning in our existence and to choose our attitude towards suffering and how we respond to uncertainty. We also utilized Frankl's work on sources of meaning. We felt that in the midst of the turmoil of a cancer diagnosis, people who were living relatively meaningful lives without being aware of the fact that they were living meaningful lives, they didn't get up in the morning and intentionally say, I'm going to do this, this, and this because that will give my life meaning. They were just going around being natural existentialists. They were living life meaning. But when you, in the turmoil of cancer, and with the loss of a sense of meaning, we thought it might be helpful to raise to consciousness these sources of meaning so people could use these sources of meaning and at some point reach for each source of meaning to help them deal with this profound sense of loss of meaning. So we took Frankl's work on sources of meaning and really focused on four sources of meaning. Creative sources of meaning. Frankl talks mostly about work and love as two sources of meaning. Creative sources of meaning are all of the ways in which we derive meaning from the process of creating our lives and creating who and what we are. So it's everything that goes into creating that. So it's our work, but it's what we care about, it's what our causes, it's our values, etc. Experiential sources of meaning. Frankl focused mainly on love and relationships, but experiential sources also refer to every way in which one experiences life leads to a profound sense of meaning. Creative sources of meaning is in some way how sources of meaning that come from engaging in life. Experiential sources of meaning come from being connected to life. The French word for meaning is sens, sense, sensation. When you're using all of your senses and all of your emotions, you're experiencing life, and when you're experiencing life fully, you're filled with a profound sense of meaning. Attitudinal sources of meaning, the attitude you take towards suffering, existential problems, limitations, unsettled fortune, and meaning exists in a historical context, and we thought that, especially for cancer patients, the idea of legacy, the legacy they inherit, the legacy they live, and the legacy they leave behind, was going to be an important source of meaning for them as well. So these are the 4 sources of meaning that we focused on. And we created a structured intervention which is called Meani Centered Psychotherapy. We studied it in 2 formats, a group format and an individual format. All right? We started out working with Meani Centered Group Psychotherapy. We focused on patients with advanced solid tumors who had about a 6-month prognosis. And what we realized, in devising this, we realized we needed a first session to introduce the subject of meaning. We knew we needed a last session to summarize everything. We wanted to have a session each for each source of meaning, historical sources of meaning, attitudinal sources of meaning, creative and experiential sources of meaning. When you have a group of 6 to 8 patients and you're going through historical sources of meaning and people are telling their life story and they're talking about the legacy they want to leave behind, it's hard to fit that in an hour and a half or 6 people. So we ended up doing 2 sessions for that. And we've run now 4 randomized controlled trials, 2 in group and 2 in individual formats. When we first started doing the Meani Centered Group Psychotherapy, we found that there was some difficulty with attrition. It's hard to get advanced cancer patients to come to the sessions every Wednesday at 3 o'clock for 8 sessions in a row. People get sick, they die, they're chemotherapy, they're hospitalized, etc. So we knew we needed to have a more flexible format, and that's when we created we adapted an individual format of the intervention, which was more flexible. We could change if someone had to cancel, we could change the date. We could even do the intervention at the bedside in the hospital. And that session is 7 sessions long because the historical session in sources of meaning is one session. Each session is partly didactic where we also realized that we needed a linking session between the introduction and the sources of meaning. And so we created a linking session on cancer and meaning. How does cancer affect meaning in my life? And the focus of that session is on identity before and after cancer. And so each session has a didactic component, which we introduce the topic, definitions of meaning, sources of meaning, and then we have an experiential exercise to try to get people to live and experience that information. And the role of the facilitators is to take whatever narratives the patients give us from the experiential stimulus questions and help try to identify the source or sources of meaning within each of those narratives, so that eventually patients are able to start to use the language of sources of meaning, identify sources of meaning and understand them so they can utilize them when one source of meaning is blocked and they need to move to another, or if they need to move from trying to enact a source of meaning through action and utilize a more passive form. So go from ways of doing to ways of being. So this is a stimulation for a first session where we introduce the idea of meaning, and it's the experiential exercise. List 1 or 2 experiences or moments when life felt particularly meaningful, a time when you felt most alive. This is the session on identity. Who am I? Write down a few answers to the question, who am I? And then before cancer and after cancer, how has it changed? One of the things we find that's quite dramatic is that the core elements of what forms your identity don't really change. The core of I'm a mother, they really don't change. There are some external elements that change, but the core elements of who you are really don't change. The historical sources of meaning. We talk about the legacy that's given, the values, virtues that you either want that you're given by your grandparents and parents, and you want to utilize them in your life, or things that your grandparents and parents did that you really, my grandmother and my father was abusive, my mother was an alcoholic, and that's the way I'm not going to live. I decided that I'm not going to live that way. That's the lesson I've learned from that. So, so it's the legacy inherited, the legacy that's been given, the legacy you live, the legacy you leave behind. The fifth session on attitudinal sources of meaning focuses on limitations and the finiteness of life. And this is the session in which we talk about death and what makes up a good death, etc. The sixth session is creative sources of meaning. We focus on responsibility. We focus on courage, commitment, care in this session. The seventh session focuses on experiential sources of meaning. By this time, patients have been talking about love and relationships for a long, long time. And this session tends to go relatively quickly and smoothly, and it sort of degenerates into joking about things. And then the last session, which originally we called termination session, until someone pointed out to me, Bill, we shouldn't call the last session for advanced cancer termination session. But you can see termination actually still appears on this slide. I didn't get to change everything on the slides, but it's changed in the manuals. And so it's a review of what you've learned. In the session on historical sources of meaning, we recommend that patients perhaps think about doing a legacy project. And about 2/3 of patients do some kind of legacy project. They pull together recipes, a photograph album, a video, a letter, whatever. Some people just say, my life is my legacy. There's a little bit of homework in the sense of, these are the exercises we're going to do next week. If you want to go over them and be prepared, you can do that. That's about the extent of the exercise.
Use the word transcendent.
Do we have time? No, we don't. So I can tell you that we've now done 4 randomized controlled trials. What each of those trials has demonstrated is that meaning-centered psychotherapy in either the individual or group format enhances spiritual well-being, meaning and faith. It enhances quality of life. It decreases hopelessness. It decreases desire for hastened death. It decreases symptom burden, distress, and it reduces depression and anxiety. All of those things that we predicted might be helped by meaning-centered psychotherapy were helped. And we've done further analysis that shows that the mediator to improving all of these variables is enhancement of meaning. Okay? And these are some of the papers that appeared in Psycho-Oncology, the Journal of Clinical Oncology, for the various randomized controlled trials. This is just some of the data from the larger meaning-centered group psychotherapy trial. I'll go through it quickly. We basically looked at patients with advanced solid tumors. They were randomized to receive two structured interventions. One is the meaning-centered psychotherapy intervention. One is a structured supportive group psychotherapy or individual psychotherapy. Battery of self-reports, which included measures of spiritual well-being, quality of life, depression, anxiety, hopelessness, desire for hastened death. In our work on desire for hastened death, we had developed and validated a measure of desire for hastened death called the SAD. And we also previously had done work on developing a symptom assessment scale. 250 patients randomized to all these groups. And all of the variables that I talked about, quality of spiritual well-being, quality of life, depression, anxiety, hopelessness, desire for death, symptom burden, distress, all significantly improved. And actually the improvement even grew more strong 2 months after the end of the intervention. The therapies are manualized now. The 2 manuals, one for group psychotherapy and one for the individual format, and they're published and available. Our laboratories now begun to expand the scope of what we use meaning-centered psychotherapy for. We've started to expand it to address problems of other kinds of cancer populations and for other purposes. So one of my colleagues, Wendy Lichtenthal, in work she's been doing with Bob Niemeyer, is adapting meaning-centered psychotherapy as a grief intervention for parents who lost a child to cancer. Wendy's also with the American Cancer Society doing an internet-based meaning-centered group psychotherapy for breast cancer survivors. Alice at Applebaum, my group, has worked on a project and is adapting meaning-centered psychotherapy for caregivers of cancer patients. Irma Verdonk and her group in Amsterdam have, Nadja van Speck developed MCP and tested it in general cancer survivors, showing it to be effective. Julia Kearney in my group is taking meaning-centered psychotherapy and adapting it for adolescents and young adults with cancer. And Lise Fillon in Canada has adapted meaning-centered psychotherapy as an intervention for hospice nurses. One thing I want to tell you is that we have some flyers outside. We have an NCI-funded T32 training grant where over the next 5 years we're training about 500 clinicians. A 2-day intensive training in meaning-centered psychotherapy. You're using actors as simulated patients, and it's free. We pay a stipend for travel. And this, there's my email. Email me if you're interested in that training. And then finally, last week I learned that the National Cancer Institute certified meaning-centered group of psychotherapy as one of their research-tested interventions that they've included in their evidence-based intervention catalog of therapy. So if you go to that website, you can actually download all the materials that we used, the manuals and all the materials we used in the randomized controlled trials. So I ran out of time. Thank you very much.